Okay, management. So we'll start with management of mild pre-eclampsia, or chronic hypertension. Management of chronic hypertension, or go and get someone coming. For this one, as you can see, the blood pressures are not so high. The proteinuria is also, as you can see, 1+, 2+. So for this, one thing about pre-eclampsia is that in our environment, if a patient comes with pre-eclampsia, you should not send them home. They should always be on admission unless they live close to the hospital. But it's advisable to always admit them because anything can happen. Because I told you, pre-eclampsia is what? Progressive. It is progressive. So she may be having mild pre-eclampsia or pre-eclampsia with mild features, but within some 1 or 2 days or within some hours, it has progressed towards severe pre-eclampsia or pre-eclampsia with severe features. And if that's the case, how are you going to attend to that patient immediately? You see? Are we getting that? So in that case, let's look at how we manage this case. So first one, let's write admit. You admit the patient. Admit. The next thing is bed rest. Bed rest in left lateral position. Bed rest in left lateral. Why are we saying that?
I'm guessing maybe there'll be...
Don't guess.
So, there'll be decompression of the aortic canal.
There'll be what? To prevent or supine hypotension resulting from an aortocaval compression, not decompression, aortocaval compression. So the aortocaval compression will precipitate what? The supine hypotension. So the patient should be in the left lateral position to relieve the aortocaval compression, thereby preventing supine hypotension. Is that clear? Is that clear? Yeah. The next one, secure IV access. Secure IV access. Take blood samples. Secure IV access. Take blood samples for full blood count. Full blood count. Full blood count. What else do you want to do? Serum uric acid. Okay. So yes, liver function test. Liver function test, BE and creatinine. Why are we doing BE and creatinine? Because in pregnancy, the serum creatinine levels should not exceed 90 micromoles per liter. If it's exceeding 90 micromoles per liter, then there's a problem. Are we getting that? In pregnancy, okay, serum creatinine levels should not exceed 90 micromoles per liter. Even in a normal female, the serum creatinine levels are around 46 to 8, okay, 46 thereabout to, oh no, it's around 52 thereabout, 52 to about 92 micromoles per liter. So in pregnancy, serum creatinine levels should not exceed 90 micromoles per liter. If it's exceeding that, then there's a problem. Please, are we getting that? Are we getting that? Okay. Then we can also serum uric acid. Serum uric acid. Then another investigation that we can do. Then we'll move to the next one. And the next investigation will be midstream sample of urine. Midstream sample of urine for culture and sensitivity. Midstream sample of urine. You know why we don't take the first urine when you're about to, because of the risk of contamination, okay? So it should always be halfway, midstream sample of urine for culture and sensitivity. The next one will be daily albumins. Daily albumins. And we know why, because proteinuria. Daily albumins. And why would there be albumins even in pre-eclampsia? Why would there be proteinuria? Have you thought about it? Why would there be proteinuria? Yes, Clifford, any idea? Oh, you did nephrotic syndrome, right? So you know, yes, go ahead.
Due to hypertension, loss of light in the kidneys and
excellent. So there'll be hypoxic injuries, okay? Hypoxic injuries due to what? Insufficient perfusion. There's going to be what? Renal hypoperfusion causing a hypoxic injury to the glomerular filtration what? Membrane or the glomerular filtration barrier. I mean, if there's an injury, the podocyte will be involved. There will be effacement of what? The food processes of the podocyte and creating what? Bigger pores for the albumins to be excreted. And that will give albuminuria or proteinuria. Okay? Okay. That's fine. So daily albumins, very, very important. Very, very important. The next one is going to be dependent on the gestational age of So in this case, we'll say that give corticosteroids if gestational age is less than what? 34 weeks. If the gestational age is less than 34 weeks, give corticosteroids. IM is good. Normally IM. We know the corticosteroid can use what? Dexamethasone, right? And if you are using dexamethasone, what's the dose? You give it IM 6 mg 12 hourly for 48 hours. But if you are using beclomethasone, it's going to be what? 12 mg daily for 2 days. Is that clear? Is that clear? So I'm saying that the corticosteroid, we have two options. We can use betamethasone or dexamethasone, or what we call beclomethasone. But mostly in our jurisdiction, we use more of dexamethasone. Most of the hospital, they will use dexamethasone. If you are giving dexa, it's giving IM 6 mg 12 hourly for 48 hours. 12 hourly for 48, that's 2 days, okay? And we know why we are doing that, to what? Mature fetal lungs, to mature fetal lungs. To mature fetal lungs, okay? Yes? 6 mg BD, that's 12 hourly for 48 hours, okay? The beta is 12 mg daily for 2 days. All right. Then next one, oral antihypertensives. Into bracket, oral antihypertensives into bracket, we can use methyl dopa. We can think of hydralazine. We can also think of what? Nifedipine. The nifedipine, we mostly use the Nifecard, okay? Nifedipine. Only if, bracket, only if BP rise. Only if BP rise. Only if BP's rise. Oh, should BP rise? Yes, that's the only time that you want to give the antihypertensives. And do you know why we are doing that? Because if you start giving the antihypertensive at a lower threshold of blood pressure, okay, it will precipitate what we call what? Excellent, watershed stroke. But if it does not precipitate watershed stroke, it can cause what? Hypotension. And if there is hypotension, there is going to be what? Hypoperfusion to the fetal placenta unit. Are we getting that? And if there is how do you call it? Hypoperfusion to the fetal placenta unit, fetal circulation will become compromised. The fetus will not be able to kick as supposed to be. So if you are going to put a pre-eclamptic patient on hypertension, that patient would have to be on what? Fetal kick count every day. Why? Because should the fetal kick count start decreasing, then you have to what? Or treat the dose of what? The antihypertensive. Yes.
So can you also say, because there's physiological increase in the blood pressure in the mid-trimester, this would negate that effect, thereby reducing the perfusion.
Physiological increase in
the blood pressure, maternal blood pressure around the second trimester. So once you put this patient on antihypertensive, it will negate this action.
But again, if it were to be severe, you have to.
Yes, so only when it is severe. But if you shouldn't put the person on daily.
They don't have the box. Okay, let it down. Okay. I got your point. But again, physiologically and pathologically, there are two different scenarios. But it's more of the hypotension. Okay, more of the hypotension. Okay. Oh, okay. Go ahead.
How about for the antihypertensive? How about labetalol?
Yeah, labetalol, yes, can be considered. It can be considered. But mostly, yes, it can also be considered. Hydrolyzing methyl dopa. Methyl dopa is, is central acting, okay? Nifedipine, and also labetalol. But there are indications for all of them, okay?
Do you have a tablet?
Yes, they have the tablets. There's an oral type. It's not only in, hydrolyzing also comes as IV, right? And it also has a tablet. So labetalol also has tablet. But we don't usually use that a lot in here. Okay. All right, that's fine. The next one, yeah, thank you. Yeah, thank you. The next thing, we said, where did we? Oral antihypertensive. Okay. Oral antihypertensive. Yes, only if the BPs rise. Only if the BPs rise. The next one, we are going to monitoring. Okay. So you are going to monitor vitals. Which vitals are we monitoring? Maternal blood pressure, pulse, respiratory rate, temperature, urine outputs, and the fetal heart rate. Fetal heart rate. That's for the fetus. Fetal heart rate. The next thing we'll be doing daily fetal key count. Daily fetal key count. Fetal key count is done from when to when? It's done for like a duration of what? Yes, about 10 to 12 hours in a day. So the woman starts at 9, ends at 9 a.m. to 9 p.m. And the fetal key count chart has small boxes, about 10. So it means that during that duration, the fetus should be able to kick at least 10 times. Are we getting that? Yes. Okay. So daily fetal key count. Yes, that should be done. Okay, that should be done. Another thing that should be done should be what? Once or twice weekly CTG. Once or twice weekly CTG. Once or twice. It means that in a week, you are doing CTG once or twice. Exactly. Once or twice weekly CTG. The next one, 1 to 2 weekly. 1 or 2 weekly. 1 or 2 weekly. 1 or 2 weekly. 1 or 2 weekly ultrasound scan to assess the fetal well-being. 1 or 2 weekly. 1 or 2 weekly ultrasound scan to assess what? Fetal well-being. The daily, we spoke about the daily urine proteins already, right? We spoke about that at the beginning, right? Okay. Then the next one, yes. Yeah, that's where we are coming to. Okay. So the next one is daily or alternate daily weighing of the patient. Daily or alternate daily weighing of the patient. When we say alternate daily, do you know what it means? Today you weigh, every other day. Today you weigh, tomorrow you don't weigh, the next day you weigh, tomorrow you don't weigh. Positive, negative, positive, negative, positive, negative, positive, like that, okay? Then the next one, deliver. Deliver baby between 38 and 40 weeks. Deliver baby between 38 and 40 weeks. 38 and 40 weeks. Vaginally or via CS based on indications. Vaginally or via CS based on indication. Vaginally, is that? Between 38 and 48 weeks.
48.
38 and 40. Oh, what did I say?
38 and 40.
38 and 40, yes. Deliver baby vaginally, deliver baby between 38 and 40 weeks vaginally or via CS based on indications. Is that clear? Yes.
The daily weighing.
Daily weighing, okay. Because of the edema. Okay, edema. Okay. Patient may become edematous. Okay. Yes. Which one? No, you don't write that sign. We'll get there, we'll talk about that. Yes. No, the patient, daily weighing. You cannot, how do you weigh the baby who is not delivered?
The fetal gains 200 grams per week.
Yes. No, it's not. Yes, there are thresholds. Okay. But if you are measuring daily, how do you see that 200? It's really significant. Do you understand? 200 divided by 7. Basically, nothing there.
So, delivering between 38 and 40. What if the mother comes at 37 weeks in labor? Would you give?
Of course, that one there, yes, that one you have to, that's 7 weeks, of course, you have to deliver. There are certain things that would make you deliver immediately. We'll get there, we'll talk about that. Okay. Yes. Doppler. Yes, that's what I say, daily. You see, monitoring of vitals, the fetal heart rate, that's what they are going to be using. Are you getting that? The monitor of vitals on a daily basis. Those vitals that we mentioned, the fetal heart rate, you'll be using what? The Doppler ultrasound scan. The Doppler ultrasound. If it's not available, you use what? The PNAD. Are you getting that? Because the midwife or the nurse, the attendant nurse would always have to be checking the fetal heart rate. The blood flow. That one, yes, that can be done, but it is not something that you do. That one should be done around 34 weeks of gestation. Doppler ultrasound scan, yes, to check what the flow of blood through the umbilical cord. How do you call it? Kinetics and umbilical flowmetry. Yeah, flowmetry. Whether the blood is flowing well or not. Yes, it's true. That will be entailed in the ultrasound scan. Yes.
Is it necessary to put the woman on salt and water restriction?
It's not necessary. Oh, yes.
You mentioned about when the creatinine exceeds 90.
Yes.
So when that happens, what differential or what important?
So that would, yes. So when it happens like that, it means that the kidney there's significant renal hypoperfusion, which is impeding on effective creatinine clearance. You see, if the creatinine is not cleared, it should be retained in circulation, and the levels will go high. So it tells you that there's something we call PET labs. Okay, we'll talk about it very soon. PET lab, pre-eclampsia, toxicology screen investigation or labs, okay, which entails full blood count, BE and creatinine, liver function test, and serum uric acid. Okay, when they are deranged, it points to that fact that the baby would have to be delivered immediately. So it's one of the indicators of immediate delivery.
Okay, Doctor, I have a follow-up question. So with the renal failure at the hospital, I heard that renal failure in pregnancy doesn't go. Usually when the mother starts to go into renal failure, they may be forced to terminate the pregnancy.
Yes.
Why is that? Is it because maybe there will be hypertension to the kidneys which will lead to worsening of the renal failure? Or
yes, well, you see, in any hypertension, there's going to be a problem with renal perfusion. Right, guys? In pregnancy, in the presence of pre-eclampsia, what you are having there is that there will be renal hypoperfusion. All right, and that is what is going to affect the creatinine clearance. And if you don't, facilitate delivery in that case, the kidney too, you should know that it helps in getting rid of toxins via the urine. Are you getting that? So if you don't, expedite delivery, all these toxins, they will accumulate, right? And they will further cause endothelial injuries massively, such that even the fetal placenta unit, the reduced amount of blood that is receiving would further dip. Okay, and that could cause fetal compromise and also maternal compromise. But majorly it's going to affect the mother. And in a pregnancy where there's a maternal deterioration, you should terminate the pregnancy, because the mother can still get pregnant. But if the fetus is good, the mother is struggling, you cannot want to keep the fetus whilst the mother is struggling. Maternal deterioration is an indication that you should terminate the pregnancy. So if there's renal hypoperfusion, yes, the mother is the one going to suffer, and as the mother is suffering the burden of that, it will affect the fetus, because the fetal circulation is solely dependent on the maternal circulation. So if you have toxins, they will go through the placenta barrier and they will enter into the fetus. And remember, the fetal red blood cells are not so the oxidative potential, oxidative stress, their their ability to stand oxidative stress is not so great. Okay, so in the presence of those free radicals and all that, yes, you could have massive hemolysis in the fetus, and that could be a big problem. Okay. Yes.
So will there be time you will discharge the fetus?
Will there be time?
You will discharge the fetus?
No, that's what I told you, that in pre-eclampsia it's always safe to go by the anthem of no baby, no home. Because pre-eclampsia is a progressive disease. The fact that it's mild doesn't mean that tomorrow it will not become severe. It can progress very fast.
So at 28 weeks, you can stay so.
Is it?
At 28 weeks, present them with mild.
Yes, that's what I'm saying, that it's always better to keep them there unless they live close to the hospital. Unless they live close to the hospital, you may discharge them and they should come in for regular A&C visits. Are you getting that? But aside that, they should always be admitted. If not, the worst can happen.
So, now, I saw a question asking for the definite treatment. In it, there was magnesium sulfate and there was
Delivery. We'll get there, don't worry, we'll get there. When it comes to pre-eclampsia, the definitive cure is what? Delivery. Delivery. All right, let's move on. Let's move straight to the management of severe pre-eclampsia. We know the other in pre-eclampsia with severe features or imminent eclampsia. I said these two now, they are the same. Okay. So the first one, you admit, call for help and assign roles. Admit, call for help and assign roles. But before we move on, let's talk about the principles, okay? Principles of management of severe pre-eclampsia. We forgot to talk about principles, so that we'll go by that principle, okay? So the first one is to reduce the blood pressure. Reduce blood pressure. It comes in no order actually. It depends on what you want to do first, what is imminent. Reduce blood pressure. The next one is prevent seizures. Prevent seizures. The next one, corticosteroids. Corticosteroids if gestational age is less than 34 weeks. Then the last one is delivery. Delivery of the baby. And you know, delivery of the baby is considered as the definitive cure. It's considered as what? The cure of pre-eclampsia. Take note of that. Delivery of the baby is considered as what? The cure of what? Pre-eclampsia. Exactly. Exactly. So if you see anywhere in an MCQ or you have been asked, what is the ultimate cure of pre-eclampsia is what? Delivery of the baby. Okay, so you are going to be going according to this principle. Okay, so let's move on. Say admit, call for help and assign roles. Establish IV access. Establish IV access with establish or secure IV access. Establish IV access with 2 large bore cannulae. 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 Okay. The next one is you take blood samples for full blood count. Take blood samples for full blood count. BE and creatinine, that's blood urea electrolyte and creatinine. Liver function test. Serum uric acid. Okay, if you put these 4 labs together, we'll call it pre-eclampsia toxicology screen. Pre-eclampsia toxicology screen labs. Okay, so we call it the PET labs. Okay, anywhere you hear PET labs, you should know that we are talking about what? These 4. Okay, and do you know why we are calling it such? What's another name for pre-eclampsia? What's the old the older name of pre-eclampsia? The old name. You call it TOP. Yes, Nafisa. Toxemia of pregnancy. That is correct. Toxemia of pregnancy. Toxemia. Formerly, it was called toxemia of pregnancy because it was believed that in pre-eclampsia there were a lot of what? Toxins, free radicals in circulation. But later on, they realized that it has to do with something else. Hence the name change to what? Pre-eclampsia. Okay? Pre-eclampsia means before eclampsia. Are we getting that? Okay. So, these are the PET labs. So anywhere you hear PET labs, these are what you are referring to. Full blood count, blood urea electrolyte and creatinine, liver function test, serum uric acid. Okay? In addition to this, we can also, and the full blood count, what are you looking at? You are looking at the HB. You are also looking at what? The platelets. Is that clear? Okay? You are going to focus on those. Okay? But you are looking at everything. HB, platelets and all that. But your focus should be here. Okay. Other labs that you can do, you can also do clotting profile. Clotting profile will not be part of the PET labs. We can do group and cross match against 2 units of blood in case of clotting deficiency. 2 units of blood. Group and cross match against 2 units of blood. The next one, that's where this one is not going to be the blood, so you should not add it to the blood. It's going to be midstream sample of urine for what? Culture and sensitivity and what? Routine examination. Midstream, okay? Midstream sample of urine for culture and sensitivity and routine examination. Okay? Please, are we following? Okay. Then the next one, the next thing that we are going to do is preload. Preload the circulation. Preload the circulation with 500 mils. Preload the circulation with 500 mils of IV ringgit lactate. Preload the circulation with 500 mils of IV ringgit lactate. Preload the circulation with 500 mils of IV ringgit lactate. Then the next thing, give MAC sulfate. MAC sulfate using the Preechard regimen. So we'll talk about the Preechard regimen right now. Preechard regimen. Preechard's regimen. Preechard. Like Richard, like Preechard. Please, do you understand? Preechard regimen. Preechard. So you should know that the Preechard regimen is the most commonly used regimen in the administration of what? MAC sulfate. Okay. So let's talk about the Preechard regimen. So for the Preechard regimen, how is it done? So loading dose of 14 gram. Loading dose. Loading dose given is 14 gram of max sulfate. And you should be asking yourself, how should this be given? So this is how it's going to be given. So the loading dose, we are going to give 4 gram. Okay, 4 gram, that is 20 mils of 20%. Okay, IV max sulfate. Given slowly over 5 to 10 minutes. Do you know why we are getting 4 gram? Remember, in chemistry, concentration is equal to mole over volume, and mole is equal to mass over molar mass. Take M to be equal to 1. So if you take M is equal to 1, then you are going to have C is equal to mass over what? Volume. Bearing in mind that the molar mass is equal to 1, okay? So if that's the case, to get the mass, mass will become equal to the concentration times the volume. The concentration is either in millimoles per liter or in another unit or in percentage. If you look there, what's the concentration? What's the concentration? 20%. What's 20%? It's not 20 over 100. What's the volume there? It's not 20. Now do the calculation. What will you get? 4 gram. Exactly. Are we following? So the 4 gram that we are saying, you know, this thing comes in nebules, it comes in what? Ampoules. So if you are going to draw it, you should know that the volume that you are drawing. So 20 mils of 20%, that will be equivalent to what? 4 gram. Exactly. 4 gram, which will give intravenously, slowly over 5 to 10 minutes. Okay. Then the next one of the loading dose, we are going to give 5 gram, and the 5 gram will be equivalent to 10 mils of 50%. Just do the calculation and see. Yeah, 10 mils. So you are going to have 10 over 100 times what? 50. What will it give you? It will give you 5 grams. Is that clear? So 5 gram, yes. Yes, you can go like that. But it's better to know both, because let's say in an MCQ, in your mind is 4 gram, but you are looking for 4 gram, you are not seeing. They are giving volumes and percentage. How do you go about that? It's similar to, see, when we are correcting hyperkalemia, the first step is what? IV, that will give what? 10 mils of what? 10% of IV what? Calcium gluconate, slowly, right? Then you ask yourself, again, over 3 to 5 minutes, thereabout. Then you ask yourself, how much gram was given? Can you see if you understand it, you tell the examiner that it's 1 gram. Do you understand? So if you see, so you in your mind it's 10 mils of 10%, but in an MCQ, how much of calcium gluconate is given to correct hyperkalemia, or is given to correct magnesium sulfate toxicity? Now in your mind, you know 10 mils of 10%, but you don't know that it's 1 gram. You just have to multiply, you get your value. Is that clear? Okay. So 10 mils of 50%, that's 5 gram. IM magnesium sulfate in alternate bottles. So not alternate, sorry. In each bottles. In each bottles. 5 gram. 5 gram. That is 10 mils of 50%. Okay. IM max sulfate in each bottles. How many bottles are there? 2. So if you multiply 5 by 2, what does it give you? If you multiply 5 by 2 plus 4, do you understand? So the loading dose is 14 gram, not 4 grams. Some of you will say that it's 40 milligram. It's wrong. It is 14 gram. You saw the breakdown. Are we following? So that's the loading dose. Now, the maintenance dose. For the maintenance dose, it is going to be 5 gram, okay? Again, we know 5 gram is 10 mils of 50%. IM magnesium sulfate. Okay, 4 hourly. 4 hourly in alternate bottles. In alternate bottles. In alternate buttocks, okay, until 24 hours after delivery. Here, or in general, or after last seizure. It means that we are referring to what? Eclampsia. In that case, are we following? If you say until 24 hours after delivery, it means that one is pre-eclampsia. Are we getting that? But if we say until 24 hours after the last seizure, then you are referring to eclampsia, because it's only in eclampsia that you'll be having seizures. Is that clear? Is that clear? And even in eclampsia, if the seizures are controlled, which of these come first? You go by that. If the seizures are controlled, there are no seizures, 24 hours after delivery, you should stop the max sulfate. The reason why we use max sulfate in pregnancy is because I told you before, pregnancy is a state of hypomagnesemia. The magnesium levels in pregnancies are so low. Are we getting that? Are we following? So this is what we call the Preeclampsia regimen. Is that clear to you? Do you understand? Okay. What we call the Preeclampsia regimen. Let's talk about other regimen in case you go for, you go for an exam, you are talking about Preeclampsia regimen. There's something I want to know, whether you know all this, or you are just behaving like a parrot. They want to know, are you, having that depth of dexterity in medical knowledge, or you are just flattering to deceive? Or you are like a balloon. Your tensile strength is very, very low. Any small amount of air inflicted into you can cause you to burst. Yes? Don't worry, we'll come there. Don't worry at all. We'll come there. Don't worry. We'll come there. All right. Let's move on. Let's move on. So, other regiments. Just take note on the side. Other regiments of magnesium sulfate administration. Please silence. So the other regimen, we have what we call the Zuspan, or we also have the CBI. Okay, these ones we don't use them yet. Zuspan or the CBI. We have Zuspan or CBI. So for them, we have the loading dose. For both of them, it's going to be the same thing, almost the same thing. Then we have the maintenance dose. Okay. So for both Zuspan and the CBI, it's going to be similar. So for loading dose, you can use, and for this regimen, it's going to be IV throughout. It's going to be intravenous throughout. Is that clear? Is that clear? So here you are going to give 4 to 6 grams of max sulfate IV, okay, slowly over 15 to 20 minutes. Then the maintenance dose will be 1 to 2 grams of max sulfate, okay, 1.2 gram, 1 to 2 grams, sorry, 1 to 2 grams of max sulfate per hour, okay, per hour in IV infusion. 1 to 2 grams of max sulfate per hour in IV infusion. Is that? Is what?
50%.
Which one? Oh, but if you should know that if you are using, let me show you the trick. If you are using IV, you use the 20%. The IM you use 50%. But you should know that the 20% can be prepared from the 50%. The 50% is the standard. If you go to the pharmacy, that's what they'll be giving to you. But if you ask the nurses, okay, they have a way of preparing it. And if you've done chemistry, we have something we call serial titration, okay? But this one, it does not even need serial titration. We just have to dilute. What do? You will take, this is what you are going to do. You take 12 mils, okay, of aqua, okay? You draw 8 mils of the 50%, okay, max sulfate, and you add the 12 mils of what? The aqua to it. That will give you 20%. Do you understand? I don't want us to go into calculation right now, but you draw 8 mils of 50% max of it. You add 12 mils of what? Aqua. That's the distilled water to it. That will give you 20% max of it. Is that clear? So we have 50%. You can prepare the 20% from it. It's not a problem. You know, if you watch the nurses, most of the time you see that they are prepared. They are doing preparations. So sometimes you give the dose, but the medication that is coming, it's not coming with that dose. The IV or IM, you have to prepare. So you draw something from here, you add water, and then you get it. This is a calculation. So if you observe the nurses, realize that when they are going to administer some certain medication, they will have to calculate. And they teach them that, right? They teach them that. So draw, add. That's it. So to get 20%, you draw 12 mils of water and add to 8 mils of what? 50% max of it. That will give you 20% max of it. Okay? All right. Now let's move on. So this is our preacher regimen. I hope that is clear to you. Is it clear? So the next thing. The same thing. The same thing. Yeah, the same. It's the same. The same. The same. It's the same. So that's the preacher regimen, okay? That's the preacher regimen. Preacher regimen.